Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the season 3 of Optometry series. And today we are at the second episode. So this particular season, we are focusing on instruments parts. So we are going to deal with a lot of instruments that is of use in optometry department. And this particular episode, we're going to deal with specular microscopy and pachymetry. I'm very happy to welcome my team members, Ms. Anshika ma'am and Ms. Sandhya. Thank you so much, both of you, for your continuous support towards optometry series. I would like to call Ms. Meera, who will be talking and giving us more information about the moderator. Shakuthala ma'am, thank you so much for joining us as the moderator for the day, ma'am.
Thank you.
Yes. So we would like to know more about you. So I would like to call Ms. Meera to share more details about the moderator.
Good evening, everyone. I am Meera Jasmine, studying in third year Bachelor's in Optometry at Dr. Agarwal's Institute of Optometry. I am very happy to introduce our moderator, Ms. Shakuthala ma'am. Shakuthala ma'am is a passionate optometry educator, currently serving as a lecturer at SRM School of Allied Health Sciences. She completed her bachelor's degree in optometry from Elite School of Optometry in 2009 and began her professional journey at Sanjanapriya, where she gained extensive experience in corneal services, refractive surgery, and specialty contact lens practice. Her expertise include the use of advanced diagnostic instruments such as corneal topographers, barometer, pachymeter, and specular microscopes. With a strong interest in anterior segment care, she further specialized in managing patients with irregular cornea through Rosque and RGP contact lens fitting. Transitioning from clinical practice to academia, ma'am has been associated with SRM for over a decade, contributing significantly to teaching, mentoring, and research. Ma'am has successfully guided numerous students' research projects, several of which have received Best Paper awards at scientific conferences and academic forums. In addition to her academic responsibility, ma'am plays a key role in strengthening alumni engagement and fostering professional networking opportunities for students and graduates. Shakuntala ma'am's area of interest include anterior segment evaluation, contact lenses, and clinical optometry. We are very happy to have you with us for moderating today's episode, ma'am. Thank you for joining. The presenter for today is Mr. Maeshwaran, third year Bachelor's in Optometry student at Dr. Agarwal's Institute of Optometry. Mr. Maeshwaran, please start your presentation.
So now we are going to speak about the topic was pachymetry and specular microscopy from optical concept to clinical application. So now we can see about the pachymetry. The pachymetry is a term used for the measurement of corneal thickness. Then the normal corneal thickness varies from central to peripheral limbus. So the mean central corneal thickness as shown by various studies is 0.51 to 0.52 millimeter. So the standard deviation is about 0.02 to 0.04 millimeter. So now we can see about how cornea is in newborn and old age. So the cornea in newborn has been found that cornea on day 1 is significantly thicker and decrease in thickness as the child grows older. So it may result from the fact that the eyes in utero remain closed for a long time. Then the decreasing thickness after the first day may suggest that the hydration control becomes operative. Then the average corneal thickness in infant is 585 plus or minus 52 microns. Then the cornea in old age is significantly thicker in of 40 to 80 years than in the individual to 40 years, as it seems to undergo age to related anatomic changes. In the image, you can see there is a changes in the central corneal thickness. You can see child as a more thicker and compared to the old age. So what is the role of the corneal thickness evaluation in clinical practice? It's mainly used in the glaucoma for applying correction factor in actual intraocular pressure determination. It's also in determining congenital glaucoma to assess the amount of corneal edema. And in refractive surgeries, it is mainly important to treat the treatment plan for keratorefractive procedures like LASIK, astigmatic keratotomy, and previously even prior to radial keratotomy. So these are the values to measure the glaucoma values. So the central cornea thickness is about 445. So the IOP adjustment is about +7, and these are the values. So then is post-operative follow-up of keratoplasty. So the patients to determine endothelial cell function and its recovery and to become alert to early graft decomposition. In contact lens to assess corneal edema in orthokeratology. So orthokeratology is nothing but a contact lens. We can wear it over the night time. So during the night time, it can adjust according to the astigmatism where the patient have. So next we can see the assessing the thinness of the cornea as in corneal disorders like terrains and pellucid marginal degeneration, keratoconus, keratoconus, and post-LASIK ectasia. Other cases if corneal decomposition for monitoring and evaluating corneal edema and endothelial function as is hepatic endolytitis. So the techniques of pachymetry measurements are ultrasonic, optical, and alternate. In ultrasonic, there is a methods are conventional UBM. UBM is nothing but ultrasound biomicroscopy. In optic, we have two types, contact and non-contact. In contact, we have manual optical specular microscopy and confocal microscopy. In non-contact specular microscopy, slit scanning, it's also called a B-scan, OCT, ASOCT is nothing but anterior segment OCT and swept source OCT. In alternate, we have pentacam, pachycam, optical ray analyzer, and laser Doppler interferometry. So the techniques of pachymetry measurements are spot measurements and wide area mapping. So you can see in spot, we can do in spot measurement, this only shows the values of the value. So in wide, we can have several images, and you can see these type of images in this wide type. So ultrasonic pachymetry. So this is the most commonly used method these days and is regarded as the gold standard one. So the principle of this ultrasonic pachymetry measurements depends on the refraction of the waves from the anterior and posterior corneal surfaces. So it is a measurement of difference between echoes of ultrasonic signal pulses from transducer to the probe and the reflected signal from the front and back surface of the cornea to the transducer. So in this image, you can see the sound waves come from this probe and reaches the anterior surface of the cornea. So it is regarded as a echo 1. Then the echoes or sound waves are travel to the posterior surface of the cornea. This is regarded as the echo 2. So we can calculate the time taken between from the echo 1 and to the echo 2. With this formula, we can calculate the corneal thickness. So there are three major components of the ultrasonic pachymetry. First one is probe handle. So probe handle is a piezoelectric crystal which vibrates at frequency of 10 to 20 megahertz. Okay, this is the handheld probe which is very small, light, and easier to use clinically. Some probes have a digital readouts where the readings can be read directly. In transducer, it sends ultrasound rays through the probe to the cornea and receive echoes from the cornea. So now the procedure is when performing the measurement, the probe tip has been placed perpendicular to the center of the cornea. As corneal thickness increases periphery, lateral displacement of the probe can elevate readings as well as shift of the probe out of the correct perpendicular position. So in this ultrasonic pachymetry, This is the average value, and this is about the standard deviation. So advantages of ultrasonic pachymetry are fast, simpler, it requires minimal observer judgment, and is therefore consistent and repeatable between observers, thereby eliminating intra-observer variation. And it is portable drive. There is no need of any coupling medium required. Disadvantages is it is a contact method. Accuracy is dependent perpendicularly of the application of the cornea. So the exact point of the sound reflex and the ultrasonic pachymetry are ill-defined. So the application force may distance anterior reflecting surface by away the precorneal film and by thinning of the epithelium. Ultrasonic biomicroscopy. Ultrasound biomicroscopy is a high-resolution ultrasound machine which images anterior segment of the eye. It has got a 12.5 to 50 MHz probe so that the depth of the penetration is lesser than conventional ultrasound. So it gives real-time images of the anterior segment. Then the corneal thickness can be measured by caliper incorporated in the machine or through the UBM software after acquiring of the images. These are the image of the ultrasound biomicroscopy. So the advantages are you can examine the anterior segment examination can be carried out along with measurement of corneal thickness. It is especially useful in cases where cornea is opaque because the sound only travels, so we can send the sound behind the cornea also. So the various layers of cornea can be identified. So the disadvantages are the main drawback of UBM imaging are inconvenient. It requires emulsion oil type and coupling fluid. It is a contact method. It required for the patient to lie in the supine position during the examination. The device cannot used intraoperative and it is difficult to standardize. OCT pachymetry. OCT pachymetry uses low coherence light waves to obtain high resolution cross-sectional images of the cornea. It provides precise measurement of corneal thickness and detailed corneal maps. So its advantages are it is highly accurate and reproducible. It provides detailed corneal thickness mapping, non-contact and patient-friendly, useful in refractive surgery planning and corneal disease evaluation. So this is the OCT image of the corneal thickness. So we can measure the corneal thickness from the line using the ruler method. So now Pachycam, the Oculus Pachycam, it is a compact, portable and non-contact pachymetry and keratometer. It is mainly designed by the Oculus. So it utilizes skimpfing imaging technique. Skimpfing imaging technique, it is nothing but used in ophthalmology to capture the ultra-sharp cross-sectional images of the anterior segment of the eye. It also measures the corneal thickness and automatically correct the intraocular pressure readings. So, Pentacam. The Pentacam corneal thickness map or pachymetry map provides a color-coded 3D visualization of the corneal thickness. It automatically identifies the thinnest point of the cornea, typically 540 micrometers centrally, crucial for assessing refractive surgery eligibility and diagnosing corneal ectasia like keratoconus. So this is the image of the pentacle. Specular microscopy. Specular microscopy is a non-invasive imaging technique that produces high magnification images of the corneal endothelium. This diagnostic tool visualizes the corneal endothelium by taking advantages of specular reflection at the interface between the endothelium and the aqueous humor. These images can be analyzed qualitatively and quantitatively using automated software to help diagnose pathology, accurately monitoring endothelial disease and aid in surgical co-management. So this is the image of the endothelial tissue cells. So what is the principle of the specular reflection? From the specular reflection, the light is incident on the epithelial surface. Then this transmitted and processed to the corneal tissue. Then the light is some amount of light is absorbed by the corneal tissue, and some amount of light is reflected by nerve fibers and keratocytes. Only few amount of light transmitted to corneal tissue. Then this light incident on the posterior corneal surface. So these light are mostly transmitted into the aqueous. Only 0.22% reflected due to change in index of refraction and endothelial aqueous interface. So this reflected light is captured by specular microscope and forms the endothelial image. So you can see the image where the light is shown and reflected. So principal specular microscopy based on the focusing of light rays through the front and back surface of the cornea. Unlike ultrasound pachymetry, it uses light reflection rather than sound waves. The distance between the anterior and posterior corneal surfaces is measured optically. So where the light sources are traveled through and reach the corneal endothelium. Corneal endothelium. The corneal endothelium is the innermost layer of the cornea, consisting of a single layer of hexagonal cells. The corneal endothelium is a non-regenerative, though some evidence suggests that in vivo regeneration may be possible. Single layer of cell comprising the most posterior portion of the cornea. In a young and healthy individual, this monolayer is a relatively uniform mosaic of 5 like hexagonally shaped cells. So at birth, there is about 3000 to 400 cell per millimeter square. From the second to 8th decade, it will decrease to 2500 cell per millimeter square. In the older age, it decreases and it is about less than 2000 cell per millimeter square. So expected cell density at each age. Age at 10 to 19, the average cell density is about 2900 to 3500. At the age 20 to 29, the cell density is about 2600 to 3400. At the age of 30 to 39, it's about 2400 to 2300. And it's still reducing at the later ages. Now finally we see at the 80 to 89 ages, it's reduced to about 1500 to 2300 cells density. So function. To maintain proper corneal function, a relatively low amount of hydration is necessary. Though the stroma tends to overhydrate under normal physical conditions. Corneal endothelial abnormalities. Overhydration of the stroma, clinically known as corneal edema. As endothelial cells age and slug off, neighboring cells stretch, relocate, or fuse to maintain the leaky barrier. This process results in pleomorphism. That means a cell shape variability and polymegatism also takes place. The normal deterioration of the corneal endothelium can be accelerated by primary endothelopathies such as Fuchs corneal dystrophy or secondary corneal endotheliopathies such as traumatic surgical contact lens induced and inflammatory. So in this image, it is a healthy corneal endothelium. When the condition is pleomorphism, this is look like this. And in polymegatism, there is a variability. It is a catecta where the place are you can see this. So what are the parameters evaluated? Endothelial cell density, polymegatism, variation in cell size, and pleomorphism, variation in cell shape. So types of specular microscopes. Contact specular microscope. The microscope comes into contact with the cornea. In non-contact specular microscope, it does not touch the cornea. It is quick and easy to perform, equipped with autofocus and image analysis software. Most commonly, it is used in clinical practice. So advantages of the specular microscopy is operator independent. It is a non-invasive, simultaneous measurement of endothelial cell count, Modern instruments provide digital readouts. Disadvantages are exact point of the measurement is not required, and contact method makes cause infection and leads to epithelial damage. It's a time-consuming procedure, and it also is less reproducible than ultrasound biomicroscopic pachymetry. It is impracticable for use in the it is limited use in corneas with scarring, deposits, or opacities because these conditions distort light transmission. Clinical applications. So, assessment of corneal endothelial health, measurement of corneal thickness, and it also helps in endothelial cell count analysis and also helps in monitoring corneal disease affecting the endothelium and the evolution before and after ocular surgeries. So now we can see about the corneal endothelial abnormalities. Any irregularities in the smooth planar surface of the endothelium are seen as hyperreflective or hyporeflective areas. Hyperreflective areas can significantly inflammatory cells. Hyperreflective areas, which are more common, can denote catarrh, endothelial pigment, and endothelial swelling. We can see in this image. In this image, you can see this is a hyper and you can see the hyporeflection. Specular microscopy indices. Cell density. You can see cell density, coefficient of variation, X or 6A, central corneal thickness, number of cells counted, average cell area, and standard deviation of mean cell area. These are the normal values of the corneal endothelium. You can see this is a central density, coefficient of the variation, X6A, and central corneal thickness. Cell density. So the number of endothelial cells per millimeter square. So cell density decreases with age and disease. When evaluating the cell density, it is important to consider age expected values, as anything below the age expected average value may be an indicator of underlying disease. Patient with a cell density less than 1000 cells per millimeter square are at higher risk for developing pseudophakic bullous keratopathy. To maintain proper hydration of the cornea, 300 to 600 cells per millimeter square are necessary. When cell density falls below this critical number, the balance of stromal hydration is tilted towards cornea edema and loss of corneal transparency. Coefficient of variation. It represents the amount of variation in the cell size. The coefficient of variation in a measure of polymagatism, which occurs during corneal endothelial repair. A coefficient of a variation less than 33 is often considered normal, and elevated coefficient of variation is often considered an early sign of endothelial disease, as this is the marker of endothelial cell remodeling. In this image, you can see that coefficient of variation value. It is almost near to the abnormal value. This is abnormal value and it is a normal value. You can see it is less than 33 and it is more than 33. So it is considered as a abnormal. X or 6A represent the number of cells that have a hexagonal shape. Pleomorphism is the decrease of hexagonal cell within the corneal endothelium. As pleomorphism increases, the barrier function of the corneal endothelium decreases. A X or 6A less than 50% is considered abnormal. You can say this value is almost in the range of abnormal value. So it is considered as abnormal. So the normal value is, you can see this is a normal value. So central corneal thickness. The central corneal thickness measured during image acquisition. A thickened central cornea may denote corneal edema and reduced endothelial function. Number of cells counted. The number of cells counted in the analysis visualization of the imaging of endothelial cells is diseased corneas may be difficult. So it is important that an adequate number of cells are included in the quantitative analysis. Average cell area. Measurement of the average cell area. This number increases with the age of polymorphism increases. So the standard deviation of the mean cell area is the standard deviation of the mean cell area within the analysis. Standard deviation is nothing but the variation across the population can be measured. This is the value of the Fuchs corneal endothelial dystrophy. So this is the moderate value and this is the advanced value of the Fuchs corneal endothelial dystrophy. So it is a contact lens induced endotheliopathy. It is the image of the 40-year-old patient with a history of low decay contact lens use. These are my references. Thank you.
Thank you, Maeshwaran. That was a detailed presentation. So, very well presented. Now, I request our moderator, Ms. Shakuthala ma'am, to add a few valuable clinical inputs. Over to you, ma'am.
Actually, a very nice presentation, like you said, a very comprehensive one, which included the different types and what each one gives us, and the reports also were presented in a nice way, where he showed the abnormal and then the normal one, both in the same thing, so that everybody can understand it better. So a very nice presentation, actually. And I'm thinking, should I add anything more rather than, like this? If there are case examples, it's going to be better. But other than that, there is instrument point of view, there is not much for me to add on to this, because like I said, he has covered it very well, very extensively.
We have few questions for you, ma'am, from students' perspective. Can I ask these questions?
Sure.
Yes. So first question is, can patient have normal Pachy finding but abnormal specular finding? Is it possible to have these two abnormal findings? No? They are saying that normal Pachy finding, but in specular microscopy, is it possible to have an abnormal finding?
Could be possible, because in case if they were having a thinner cornea, or they are not, their corneal thickness in general, if it is less than what was normal, then in case of edema, we expect a swelling, but then their normal might be the increased corneal thickness. So yes, definitely you can see changes in the endothelium, but the patient's pachymeter might be normal, because we don't know their baseline pachymeter value. So, which is why we usually say that, in case of contact lens, where you expect somebody to have uh, corneal edema in a long run also, we always say that it's better to have a baseline value. Because that's when we know whether there is a change, or change due to edema, or whether that is the normal corneal thickness.
Yes, ma'am. Thank you, ma'am. So the second question is corneal thickness measurement important before cataract surgery? Because we all know, so we'll take corneal measurement before refractive surgery. So in glaucoma cases, so is it important to take corneal thickness measurement before cataract surgery?
That's mainly for your eyeball calculation and things like that, yes. But taking a specular is more better, because that gives you the endothelial health rather than doing just a pachymeter. So I would say, I mean, in case if the patient is going to go for corneal decompensation or not, for us to know that, it's better if we do a specular and see how their endothelium is, rather than go for a pachymeter.
Thank you, ma'am. So we have two more questions, ma'am. I'll ask the third question. So the third question is, how significant are diurnal variation during corneal thickness measurement, ma'am? Will they affect the clinical decisions, or will they affect the findings, the diurnal variation?
The diurnal variation is mainly you're asking in terms of IOP measurements.
Yes, but no, ma'am. The question is from students. So we know that during IOP measurements will vary during the diurnal variation. They're asking, will corneal thickness measurement also vary?
No, that's not going to vary. That's not the reason why there is a diurnal variation in the IOP, right? Because what we do is, or the change is going to be there because in applanation or in uh, any other principle which tests the IOP, it's going to take the corneal thickness into account. But then that's not going to change that significantly in the day. Usually they say in the morning might be there is a little bit of corneal swelling, which is normal, like 2%, 3% or so. But then it's not going to play a significant role in the diurnal variation of UPI.
Thank you, ma'am. And the last question is, so how do contact lens wear and long-term lens use affect endothelial morphology?
Like we always know, or we usually say, right? This is definitely this was a major concern prior, because when lenses didn't have the required amount of decay, or when patients used to, overuse contact lenses, yes, then it was a problem. But now with better lens options, and with lenses having good decay, I really don't think that there should be any long-term effects because of contact lens in the endothelium. But if in case the patient is going to overuse, or they are using a hydrogel material, it really depends on the oxygen that is going inside the eye, right? So if in case they are going to use a good lens, I feel that there shouldn't be any much endothelial changes due to contact lens.
Thank you so much, ma'am. So that's all from my side. Thank you for patiently answering for all those questions. So thank you, ma'am. That's all from my side. Anshi, ma'am, do you have any points to add on?
Hi, Shaku. Sorry, I joined very late.
That's okay.
No, I think it was comprehensive. I think you did a very good job.
Actually, the presenter did lot of things, so that my job was very easy here.
Yeah. So I don't think I will add up anything. It's been great that we've been able to discuss how corneal thickness and specular evaluation plays a major role. Being an optom, we should know how to check for the corneal thickness, and we should also know what are the normal values. So if we have any values that come across to us, whether it is a thick or a thin cornea, so we should know, because nowadays one thing that I would like to bring about is about LASIK. People nowadays are going a lot about these corneal refractive surgeries, and it is important for patients to know that there is a minimum corneal thickness which requires before you go for any refractive surgery. So that is something which every optom should pass on the information to the patient, that undergo these procedures before you undergo any refractive surgery. And specular, as Shakuthala also rightly pointed out, for post-cataract surgeries or contact lens users, now it does not affect much, but we should also know how to read a specular report. So that gives us the idea about the endothelial health. So thanks, Shaku, and thank you to the presenter for really presenting it well. Over to you, Gomati.
Yes, Anshi ma'am. So thank you so much, Anshi ma'am. Thanks for roping in Shakuthala ma'am today. And Shakuthala ma'am, thank you so much for patiently answering all the questions, ma'am.
Thank you for inviting. Happy to be here.
We would like to host you on another wonderful platform, ma'am. Maybe physically here on one nice occasion.
Sure. Looking forward to it.
Yes, thank you, ma'am. Yes, thank you, Meera, for being the MC for the day. And Maheshwaran, that's an excellent presentation. The presentation was really good. I would like to mention Sandhya, ma'am, for pitching in and making it. I think it's an exam worth presentation. So people can actually pitch in and watch the presentation before examination, optometric instrumentation. I think I'll put this word to all the second year students. Just to use this presentation during their exam preparation. And it was wonderful thing that I know this happened today. This is the very second episode. So the third season has started very well. So Shakuthala ma'am was the part of the third season. So we're so happy, ma'am. Thank you so much.
Thank you.
Dear audience, thank you all for your continuous support towards Optometry series. I would like to thank my team members once again. Anshika ma'am, thank you so much. Sandhya ma'am, thank you so much. If you like this video, give a thumbs up and share with all your friends. We'll meet you in the next episode. Thank you all. Bye, ma'am.
Bye.